just 15 questions. We're just going to show you how, when you study these kind of subjects, you should pay attention to certain strategy, because it's a really interesting topic. Just some key facts, and you can make up the symptoms based on what you know. Which of the following is the most effective? You see, the big word is what? Most effective way to treat high magnesium. Patient magnesium is very high, right? But pay attention. A nurse is caring for a client with what? Baseline creatinine of 3.5. How are you going to treat this patient potassium, magnesium? The magnesium is 4.5. It's too high. How are you going to deal with it? You have to focus on this and forget about that. So focus on the baseline creatinine, right? Like I said, it's a strategy, but it's clinical thinking. You have to think about it. This patient creatinine is 3.5 baseline. This is where she live, or he or she live. The magnesium is like 4.5, and you want to treat it. What do you think? You can put your answers. Do you give a large volume IV fluid, a phosphate binders, diuretics, or dialysis? What do you guys think? Think about it. You have to pay attention to the buzzword. When I keep on saying that, there's a reason why. When I said the question, I emphasize on that. The only way you can treat this patient is by looking at the creatinine. I keep on saying it again. Why do you have to look at the creatinine? 3.5 is what? This guy is in renal failure or chronic kidney disease. Every answer choice has to be based on that. Chronic kidney disease. So if I have chronic kidney disease and my magnesium is 4.5, will you give me a lot of fluid? This patient will not tolerate that fluid. He will not like the fluid at all. He's in renal failure. Will you give him fluid? It will be fluid overloaded. He will hate it. The phosphate binder is not going to work. This is not calcium problem. The diuretic, the kidney is not working. What are you going to do with that? You have to dialyze the patient. When somebody is in renal failure and he has electrolyte problem that you get to be effectively take care of it, you have to dialyze the patient. That's why I say pay attention to that. 3.5 is your problem. 3.5 is creatinine, is telling you is in renal failure, and dialysis is the most effective way to take care of the patient. So once again, strategy, but at the same time, bringing your content. So the right answer is number 4. You have to dialyze the patient. Each of the following electrolytes the nurse should prioritize to monitor. The client is prescribed Etacrynic acid for CHF. Just 2 words. Etacrynic acid for CHF. And then what electrolyte will you prioritize? You bring your pharmacology and you add it to fluid and electrolyte. This is what? It's a loop diuretic. And what is the biggest? If you don't recognize it, it's a loop diuretic. Just write its friend. Its friend is what? Furosemide, right? If you know furosemide, what are the things you worry about furosemide? Then you use it to answer the question. So what are the things? What are the things you should worry about? What are the things you should worry about? The most dangerous thing about furosemide, they get dizzy, orthostatic hypotension. It's a sulfur drug. But the most dangerous one is hypokalemia and what? Stevens-Johnson syndrome. So this is not a problem. This is not a problem. This is not a problem. This. You see what I did? You break it down and you know what you're looking for. It's a prioritization question. This is more dangerous than all of them. And this lead to, if you look diuretic, they deplete your potassium and some of your sodium and some fluid. Potassium is really, really lost. So that's the most important thing. Each of the following order, the nurse should question something wrong with the order. Okay, a client with NG tube for 3 days need electrolyte replacement. I give you the value. Don't worry about it. 3.2. You have K of 3.2 and you want to replace. Don't worry, don't freak out. Look at the problem. All I'm asking you, I'm explaining to you when you're taking the test, you should do that. I have a potassium of 3.2. How am I going to replace it? There is a principle. And what is the principle of replacement of potassium? What do you guys think? What is number one principle you should know when you're replacing somebody potassium? No IV bolus or push. That's all. This is the principle of potassium replacement. You never push IV potassium. So don't give it IV directly. This is an infusion. The potassium, I make it so complicated. That means you have what? 150 milli equivalent of potassium in 500, okay, over what? Normal saline over 5 hours. This is an infusion, so it's good. Another infusion, 50 ml of 50 milli equivalent of what? Of potassium in 500 of normal saline over 8 hours is good. So for us, it's getting 10 milli equivalent over an hour, we good. I'm also infusing this 20 milli equivalent in 500 over 4 hours. We good. We can let them take it, but give it with the meal so that they don't vomit. Okay, it's a big pill. It's very big, and it can make you nauseous and you can vomit. Therefore, and it can cause esophagitis. So you give it with what? Meal. This 10 minutes, 30 milli equivalent over 10 minutes, this is an IV push. So all this is testing you, all these up there is to try to confuse you. Okay, but they are nothing. You're looking for something that says no, 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 no. Never push IV. And this is pushing IV. The rest is all right. So far as it's under infusion over certain hours and you're taking it, is good. Okay, so 5 is your right answer. Due to the following clients, the nurse should anticipate the lab value belongs to based on the clinical situation. I have electrolyte and I make something out of it. And nurse is caring for 4 clients. The lab value of serum sodium of what? 131. Look, 4 sentences. Forget about it. All you got to say is, I have sodium 131. Sodium 131. Who is responsible for this? Who is going to cause? Which situation will make me have this kind of problem? The client 24 hours after lab appendectomy. Usually after you remove your appendix, you're already at home, you're eating. If you're lucky, unless something happened, but if it's 24 hours, he's in the hospital, probably he's eating, ready to go home. There's no way he's going to be getting fluid or something to cause hypokalemia, a hyponatremia. So you're likely to eliminate this out. 24 hours, X-fix. We just put X-fix in your leg. You're not getting fluid. We're not doing anything to you. There's nothing that shows that I'm giving you a bunch of fluid, I'm diluting your sodium. Probably this patient who is eating. Don't worry about it. It's all this. What is going to cause hyponatremia? 24 hours after transureteral resection of the prostate. What do you do? When you take the prostate, okay, when they remove the prostate, we do what we call continuous bladder irrigation, 3-way catheter. We put fluid in the bladder and wash it down and let it come out back and forth, large volume, for sometimes 4 days. Continuous bladder irrigation. Number 1 cause is hyponatremia. Fluid and electrolytes, they can take you everywhere. So this is what I've taken you, because it's hyponatremia. So this is the culprit. Laparoscopic cholecystectomy, like I said, 24 hours, already gone home. They're not going to be receiving any more fluid. So this is the only patient who is at risk of getting fluid, and they get transureteral resection for prostatectomy syndrome. So 3 is your problem. This is a little bit slight thinking with this question, a bunch of words, but it's the same thing. You just have to rewrite it again. Which of the following clients the nurse should anticipate the lab value belongs to based on the clinical situation? The client sodium is what? 131. Or I'm asking you, which of this will cause hyponatremia? That's all. So figure it out. Which one will cause hyponatremia? What is prednisone? This is steroid. And you know, if you know your endocrine, you know steroids is related to the aldosterone. And aldosterone loves sodium. So your sodium is high. There's no way chronic use of steroid will cause that. Do you recognize this? What is that? What do you think this medication is? It's a potassium sparing. What does potassium sparing do? When you spare potassium, you hate sodium. Sodium go down. So those guys causes hyponatremia. Do you recognize this? Conivaptin. You should. Right? Do you know what it's used for? Think about SIDH, right? You think about SIDH, this block ADH, that we use it for SIDH. It blocks ADH. Therefore, you cannot absorb more water to dilute your sodium. So your sodium will go up. So they will not cause hyponatremia. Do you recognize this? You break down the question, just break it. This is select or apply. You don't have to pick everything. If you're confident with that, pick it. If you're not, leave it. You don't have to select all, but I want you to master it and break it down like I'm breaking down so that you can get used to it. What is that? This is ACE inhibitor. What does they do? I call them potassium sparing because they do the same thing. They cause high potassium and they get rid of your sodium. That's the way they help with your blood pressure. Okay, so this will cause hyponatremia. If I'm giving you sodium, it's no brainer, right? There's no way your sodium is going to go down. Sodium polystyrene, that is K-acylate, your sodium will go up. So the right answers are 2 and 4. This is a very good question, critical thinking. I just want you to think about it. Each drug, bringing your pharmacology and breaking it down slowly and slowly and slowly as you walk through. Okay? Okay, same strategy, right? Select and apply. Which of the following the nurse expect to administer based on the lab results? The nurse is caring for the client with calcium of 14. Okay, you have calcium 14, way too high. We got to bring it down. Okay, we have to bring it down. If you have to bring it down, whenever something is too high, if you had fluid, it's going to bring it down. So this is no brainer, right? Flush the calcium out. So when you give them a fluid, you got to flush it out. What medication help you flush things out? What medication? I give you a bunch of fluid, but I got to flush it out now. What medication do you think you can use to flush the calcium out? His name is what he does. He flushes things out. What do you guys think? I give you fluid and I want to wash it out. What should I chase the fluid with? Furosemide, right? Furosemide will flush you out. And you know, calcium and phosphorus, they hate each other, right? Calcium and phosphorus hate each other. If calcium is high, phosphorus is low. Well, if your calcium is high, I'll give you more phosphorus so that I can bring your calcium down. So this is good. Vitamin D will help with absorption of calcium, and that will increase your calcium. Therefore, we don't want this. Calcitonin basically breakdown of bone so that your calcium does not increase anymore. So that's that. So this is the treatment of hypercalcemia, 1, 2, 3, and 5. Number 7. Which of the following the nurse expect as potential etiology? Think about these answers. A nurse is caring for a client with what? High magnesium. Which of the following the nurse expect? What do you think? Which of these do you think will increase your magnesium? What do you guys think? This one, you know, SIDH, there's no way everything is going to be diluted. You're absorbing too much fluid, free water, right? Free water from ADH. I'm bringing just content. I'm using, when I answer a question, it's all content. You know, I know that free water is getting absorbed. So magnesium will go down. Same thing. I'm going to use the same strategy. Cushion, right? It's going to hold on to sodium and I hold on to water. Magnesium, you're going down. Aldosterone, the same thing. I hold on to sodium and water. Magnesium, you're going down. Test taking strategy. It has to be this. Okay, it has to be this because they have the same etiology, they have the same principle, they're working with the same principle. Therefore, you believe it. This is dehydration. So things, you lose free water. Most of this, you're gaining free water. So there's no way dehydration will cause hypomagnesemia. You will increase things up. That's just to make you think about this question. Which of the following the nurse should expect an assessment based on the lab results? Select or apply. The nurse is caring for a client receiving magnesium drip. Magnesium level of 4, right? It's too high. So you have high magnesium, right? The way to remember magnesium and calcium, when the level is high, I call it inverse relationship. Symptoms will go down. If calcium is low, their symptoms will go up. So this magnesium is too high. I expect things to go down. I expect things to be going down. Okay. So if you're getting magnesium drip, we should be watching for things not to go too down. If you keep on going down, we are in trouble. Reflex is going up. That's a problem. It's in the negative way. I don't expect that. If you're getting magnesium drip, that means I'm not giving you too much magnesium. And then with the level of 4, yeah, I don't expect that. Your respiratory is going up. I don't expect that. Your heart rate is going up. I don't expect that. Your SAT should be going down. Yeah, this is what I expect. So you have to do the relationship. High magnesium means symptoms should go down. These symptoms are going up. Okay, when you do that, it's easy so that you don't have to memorize. It's the same thing. If I give you low calcium, you know, your symptoms will be going up. So if calcium is low, this is fine. Or magnesium is low, but patient is hyperreflexive. It's not, that's not going to happen. This is all the principle. You got to apply the principles, and that will help you solve the question. Okay. Number 9. Which of the following the nurse should expect based on the lab results? I've already given away this answer choice. A nurse is caring for a client with serum phosphate level 4 times normal. So your phosphorus is 4 times normal. What would I expect? Do I expect the sodium to go down, magnesium to go down, phosphorus to go down, calcium to go down? Concept, like I said, it's all concept that you know. What do you know about phosphorus when it's 4 times? Which of these lab results do you expect to go down? That's all. That's what the question is asking you. Rewrite it. Don't overthink it. Which of these you expect it to go down? I already told you the answer, right? The phosphorus, yes, what? Inverse relationship with what? Calcium. Therefore, its phosphorus is high, calcium is low. That's all. He has no relationship with sodium. He has no relationship with magnesium. He has no relationship with phosphorus. He just has what? Calcium relationship. The only person he has relationship with is calcium. Only calcium. So I expect this. These numbers are just trap. I made it up. The principle is high phosphorus will lead to low calcium. That's all. That's the only one he has relationship with. So that's the answer. So the answer is number 4. Number 10, you have to know how to treat fluid electrolyte. Which of the following the nurse should once again expect in the plan of care based on the lab results? So what do I expect in the plan of care based on the lab results? A nurse is caring for a client with what? Sodium 150. Sodium 150. What is this? Hypernatremia. Just rewrite the question. All we have is sodium of 150. It means hypernatremia. So we have to make this normal. How do you make this normal? There's a strategy. It's straightforward, right? If your sodium is too high, I should not give you anything more than 1%. That's all. If the sodium is too high, is higher than normal, you should get something less than 1%. I shouldn't give you anything higher. I should dilute your sodium. If you restrict them from drinking water, sodium goes up. You got to dilute the sodium. So give them something to dilute it. Give them free water, just water. Water will make this normal. So restricting them is not good. I said, if your sodium is high, give them something less than 1%. This is what? 3%. I'm not giving it to you. Of course, furosemide will get rid of your what? Sodium, right? So that's good. What do you think about this? This demicycline, he also block ADH. If I block ADH, I can't get any more water. My sodium continue to go up. I don't like it. Demicycline is used, okay, for people who have what? SIDH, so that they don't what? Absorb any more water so that your sodium can go high. The patient's sodium is too high. This is not normal. This sodium is less than 1%. So I give you half of the percent. So this is good. So 3 and 5 are your answers. Somebody said, I should explain the word expect. Which of the following the nurse you expect in the plan of care? So that means if the doctor is making a plan of care to be given to the nurse, what should the nurse be anticipating? Is the same thing as anticipate for. What do you think will happen? How are we going to treat the patient? What do I expect in the plan of care? What should be included in the plan of care for a patient with the sodium of 150? We got to bring the sodium down. So we're going to do things to bring the sodium down. The things we do to bring the sodium down is to let them drink water, not restrict. So restrict is bad. Let them drink free water. Don't give them any more sodium. It's 3%, is too high. Get rid of the sodium with furosemide. You don't block ADH because ADH is going to absorb water and dilute your sodium. If you block it, it's not good. You can give them half normal. That will bring the sodium down. So 3 and 5 are your answer. Fluid electrolyte requires some thinking. Okay. Which of the following is a priority? A client presents to the emergency room and lab evaluation shows potassium of that. I have potassium 6.5. What do you want to do? Admit me to the ICU, give me insulin and D5 the dextrose, dialysis, or give me an EKG. What do you mean by free water is dextrose D5W. This is free water. Sugar in water, or just water, regular water. This is free water. D5W is free water, or just regular water we drink. Okay, water we drink. So D5 free water is the same as D5W or regular water. Okay, 6.5. What do you want me to do? I'm worried about the heart. cardiac overstimulation. So cardiac overstimulation is my priority. That's why hyperkalemia, the first thing they get an EKG and they get stabilization of the heart with calcium gluconate first. When the potassium is too high, we worry about cardiac. So cardiac problem. If I'm worried about cardiac problem, I need to get something to tell me if they have peak EKG, peak T wave, there's EKG changes. I can stabilize this with the calcium gluconate. Prioritization. I told you guys, you have to be sharp. What is going to kill them is a cardiac problem. And so for cardiac problem, I need my EKG so that I can have my calcium gluconate and deal with the EKG changes. Okay, guys. Arrhythmia, excellent. So I will do this one first. Like you can get it done in less than 2 minutes. And then if they need calcium, you give them quickly. You have to get the insulin and everything. Don't worry about that. The heart is the problem. One question we saw but in the different form. Which of the following the nurse may suspect to be the cause? Suspect to be the cause of this lab work. The client presents to the emergency room and lab evaluation, so potassium of what? 6.5. So what will increase your potassium? That's all. That's all you need to. You have to rewrite the question so that it became easy. You see, I just focus on this. 6.5. That's all I care about. What is going to make my potassium that high? Then you look at the individual situation and make sense out of it. Bring your pharmacology. And if it makes sense, you pick it. If it's not, you leave it. So this is select or apply. Clients on lisinopril. What do you guys think? Does it make your potassium 6.5? You bring your content. Lisinopril is ACE inhibitor. It causes angioedema, cough, electrolyte problem, and that electrolyte is your potassium. And the I, because it's a teratogenic. You cannot use it in pregnant lady. Therefore, this is a problem. Client on spironolactone. What is this? It's a K-sparer. Therefore, potassium will be 6.5. Client with Kuhn's syndrome disease. Do you know this? This is aldosterone tumor. Aldosterone loves sodium and hates potassium. Potassium down, sodium high. Therefore, this is wrong. Metabolic acidosis. Today, if you don't know this, I'll show you. This is the cell. There's two things you have to know: metabolic acidosis and metabolic alkalosis and their relationship to potassium. If this is the cell, okay, when you have metabolic acidosis, that means you have acid here, a lot of acid here. Your body does not like metabolic acidosis. Therefore, it pushes the acid inside the cell. This is inside. This is the blood. If you push the H plus inside the cell, you got to balance it with something. Potassium, you have a bunch of potassium inside the cell, and less potassium outside the cell. That's why your body don't hate potassium. You want to keep all the potassium inside the cell. But if you bring in H plus acid inside, potassium has to exchange it, which is also plus. So you have more potassium coming out. Therefore, metabolic acidosis causes hyperkalemia. Do you know why? Have you seen it somewhere? Do you know this guy? Have you heard about this? I know you know it. Don't learn in isolation. You remember these guys? DKA. When they come in, what do you see? What is their lab work? Initial potassium. Is it low or high? Initial potassium in a DKA patient, what do you see? If they give you a select or apply, a patient came in with diabetic ketoacidosis, initial lab work, what do you think you see? The potassium is high because they have acidosis. That's their body trying to fix the acidosis. So metabolic acidosis causes hyperkalemia. So this is also good. This question is the same as that. Hypoaldosteronism. I told you aldosterone, it loves sodium and hates potassium. If your aldosterone is low, sodium is going to be low and potassium will be high. So hypoaldosteronism will cause hyperkalemia. It's all about content. You don't have to pick all of them. I try to make it hard for you to spend time trying to break it down. It's frustrating, but to figure out which direction. But these are the way they will set the question. So mastering is fine. You can, there's 4 of them. If you choose 3 or 2 and you get it, yeah, keep on moving. You don't have to get all 4 right. It's okay. Okay. That is the way to do it. But you don't need to get all 4 of them right. Number 13, of course, we got to look at fluid status. Select or apply. Which of the following the nurse expect on assessment? What should I see, expect? Me, I should see this. If I see this, that's what expect means. If I see this, I should see that. A client present to the emergency room after what? 5 days of severe diarrhea. 1, buzzword. Decrease oral intake. 2, buzzword. Fever 102 after 3 days of camping. 3, buzzword. There's a bunch of distractors there, but don't worry about it. Put it together. I have diarrhea, I'm not eating, and I have fever. What would this cost me? What would it, and I've been camping for 3 days. What would I lead my body to do? What state would I be? Would I be happy? Oh, no. You're not going to be happy. The body will be screaming for something to feed him. Feed me, I'm dying. So this patient, what do you think the patient, what state is the patient in now? What do you guys think? You can type the answer. So what do you think? These are buzzwords. It's a case form in the short form. 5 days. 5 days of diarrhea. 1, and you don't drinking. 2, and you have fever. 3, and you've been camping. 4, in the hot weather. Probably dehydration. That's all. That's all. That's what the question asking you. That's what I tell you, is to spend some time. Don't worry about the fever. Put it together and say, oh, this patient is dehydrated. Therefore, if he's dehydrated, your skin is going to be moist? No way. Right? Skin is going to get dry. Your mucous membrane will be moist? No way. Your heart rate 70. I've never seen that before. Your urine, how is it going to smell? Clear? You're going to smell like water? Or something that will be stinging your nose? What do you think? Does it smell good? Your urine? What do you guys think? How would the urine smell? Pungent. Urine specific gravity of that. I want you guys to think, right? This is your normal urine specific gravity. Is this within this range? This is 1.028. This is the normal range. 1.003 and 1.030. This is within this range. Do you expect their urine to be within this range? Specific gravity is going to be concentrated. So this urine specific gravity is wrong. It has to be greater than 1.030. So this is wrong. They're going to be what? Lethargic, right? They've dehydrated. And finally, the central venous pressure of 25. What do you guys think? Do you expect this? A CVP of 25. Do you expect this on exams? If you examine this patient, do you expect a CVP of 25? CVP. The CVP indicates fluid status. So if the fluid status is low, do you expect the fluid status to be high? No. Normal one is 2 to 8. This is almost 3 times normal. You don't expect this. So 1, 4, and 6 are your right answer. Which of the following EKG finding the next should include based on the lab value? And this is teaching new graduate about electrolyte. Peak T wave. When do you see it? High potassium. So this is too low. Shorting QT interval. When do you see it? High calcium. This is too low. Prolonged QT. When do you see it? Low calcium. This is too high. High potassium. You see peak T wave. When you see wide QRS complex, they're about to die. That's the deadly rhythm. So this is your right answer. This is one of the features. You start with the peak T wave and you start changing and changing until you get QRS complex, become a problem. Same thing, we're back to the fluid so that I can see what you guys know. And then she's teaching you graduate about fluid. Which of the following is hypertonic? Meaning is greater than 1%. That's all. You see what I said? 1%. Lactate ringer is isotonic fluid. 0.9 normal saline, isotonic. D5W, I need to explain this. If this is a bottle and you have D5W, that means dextrose in water. If it's sitting there, it's hypertonic. If you infuse it in the individual, the liver will break it down. It becomes hypo. Don't forget that, hypotonic. So D5W in the bottle is hypertonic. After infusion is hypotonic. D5W after infusion, hypotonic. anything greater than 1%, this is 5% normal saline, is good. Hypertonic. 0.4%, this is half. But if you have D5W to rate, is what? Hypertonic. The way to master them, if they say isotonic, it's just normal saline and LR. If they say hypo, it has to be less than 1%. If it's hyper, it's greater. So 5% normal saline, 3% normal saline, 10%, yeah. Then you have to deal with the D5W. Yeah. If it's in the bottle, it's hyper. If it's infused, it's hypo. D50, if they give you D50 dextrose is 50%, this is hypertonic solution. So if you need more information on this, I have a video, Fluid and Electrolytes and ADAPT NCLEX, you can watch. It's just one video, but it's everything, all the electrolytes, how to master them. It's just an hour, how to check fluid status and how to manage patient. Straightforward questions. Thank you for your time. Have a good night and all the best of luck. Any question before? Okay, so I will log off now. You guys have a good day. All the best of luck.